today. Welcome, everyone. We're going to get started in just a moment. Thanks for joining us for today's webinar. Welcome, everyone. We'll get started in just a moment as folks trickle in. Thank you so much for being with us for today's webinar. Well, with that, hi all. I am Michael Morella, Managing Editor of Events at US News and World Report. Thanks so much for joining us for today's session. Today's webinar focuses on pediatric care innovations that work. We've got a distinguished panel of guests from children's hospitals across the country who are here to talk about the cutting edge research and care for young people. Before we get started, just a couple of programming notes. As always, you can find more about today's speakers and past and upcoming events at usnews.com/events. We are recording video of today's session, and we'll be making that available to viewers once the webinar concludes. Look for a follow-up email from our team. And later on in the hour during our panel, audience members will have the opportunity to ask questions. So if you have them, we ask that you please type them into the Q&A feature in Zoom on your screen. Our moderator will try to give voice to some of those as we have the time. Now, first, I'd like to introduce Dr. Howard Weiner, Chief of Neurosurgery and the George A. Peterkin Jr. Endowed Chair at Texas Children's Hospital and Professor and Vice Chair of Neurosurgery at Baylor College of Medicine. Welcome, Dr. Weiner, and thanks so much for being with us today.
It's a pleasure. Thank you so much for the invitation. It's great to be with you today.
Now, you're a neurosurgeon and you have special expertise in pediatric epilepsy and brain tumor surgery. Can you give our audience a quick sense of the state of the science in this arena?
Thanks so much, Michael. So I'm a pediatric neurosurgeon, and over the last 25 years or so, have sort of found myself taking care of lots of children with medically refractory epilepsy and brain tumors, especially brain tumors associated with seizures. This is an incredibly exciting area, sort of representative of the best team collaborative neuroscience that we do. I think there have been several major advances, both philosophical and technical, and I think these sort of work together. I think, just by way of background, epilepsy is a very common problem that we see in neurosurgery in children. It affects about 1% of the population. It's typically treated with medication. About a third of the children that we see are not controlled with medicines, and the seizures wreak havoc on their lives. They can't go to school, they're in the emergency room often, the families often are in crisis. Many of the children that we see are on multiple medications. So surgery is a way to get them out of that situation, offer some semblance of hope. Surgery is based on the notion that there is a focus or an area of the brain, a hotspot, if you will, where the seizures are arising. And so typically what we'll do is we'll do an evaluation where children will undergo imaging studies, functional studies to localize the seizure focus. I think one of the major advances is that now, over the last 20 years or so, we are offering this type of approach to many more children than were candidates in the past. The reason for that is twofold. Number one, it's clearly recognized now that seizures are very bad for the developing brain of a child. All of the developmental milestones that our children achieve are hindered by seizures that are not controlled. And we also know that surgery is safe. And we now offer surgery to very young children when their developmental progress is really at a rapid slope, and we can have the highest impact. So I think this notion that epilepsy surgery is an option for children has really grown and developed. Also, our modes of studying and understanding where the epilepsy is arising in the brain has really advanced. So now we have many non-invasive studies, MRI, MEG, PET, SPECT, that all of our children undergo as part of the evaluation. And the question is very straightforward. We want to know where in the brain the seizures are starting and whether it's safe to target that area with surgery. What's happened over this, I would say, the last 2 decades is that our testing has really improved, and we're offering surgery now to many more children. And the way we do surgery also in contrast to the expansion of candidacy, has become much smaller and less invasive. So now we're able to study these children with intracranial electrode studies that are less invasive. Children can go home in a shorter period of time. There's better comfort for the children, and we can understand the epilepsy in a much more detailed way and less invasive way. One of the techniques that we've adopted is called stereo EEG, which is a surgical procedure to really localize and pinpoint where in the brain the seizures are starting. And we can also offer, instead of our typical brain surgery approach, which is to go in and find that hotspot and remove it physically, we can now do that minimally invasively with laser. We can actually go to deep areas of the brain that were perhaps accessed with higher risk. We can do that with much less risk and treat these lesions. I think some of the major advances have been in children who have multiple lesions of the brain, who have more diffuse kind of epilepsy. We also recognize that the way we understand the outcomes in these children may be different. We may not be going for complete seizure freedom in every single child. It may not be appropriate or possible. But if we can target the seizure that is most detrimental for that particular child, then we can really impact and help them and help their families. So this has been incredibly rewarding over the last 25 years that I've been doing this. I stay in touch with pretty much all of my patients. I hear from them. And this is an opportunity to really impact in the quality of life of the children and the families. In the areas of brain tumors as well, we've seen tremendous strides in the molecular profiling and understanding of these tumors. So there are tumors that are benign or low grade, and then there are more high grade or malignant type of tumors that we deal with. I would say that the survival now has really advanced as a result of our understanding of the biology of these tumors. And we work very closely with our colleagues in oncology and neurology and radiology to really offer patients the very best in terms of molecular-based therapies. As far as surgical approaches to brain tumors, we're always aspiring to be better. We have intraoperative MRI scan. We have microscope. Some of the exciting things down the road that we're offering are completely incisionless surgery. We can talk about that if you'd like. But I would say that where we are now compared to where we were when I started is dramatically different. And it's opened up many, many possibilities for our children and their families.
Yeah, you've kind of started to get at this, but just ask this question directly. You know, I think a lot of people hear innovation and they think about these big, bold or far off ideas that maybe won't impact individual people or families for years to come. Could you share an example of, maybe one of those patients you kept in touch with to help kind of make this even realer for our audience?
Absolutely. I mean, there are several I can think of. I'm thinking of one child who actually came to us a few years ago here in Texas when I was here already, actually referred from another major children's hospital. And that's one of the benefits of COVID now is we're all in touch virtually, and it's very easy to take care of children with colleagues at other centers just like this. So this child was referred, this was actually before COVID. And the problem was this child had a condition which we now know well as tuberous sclerosis. It's an example of an epileptic condition of the brain where children have multiple benign tumors in the brain throughout the body. It's probably the number one known cause of autism in young children. These children have severe epilepsy and their families are in crisis. And this child was considered very challenging. The epilepsy could not be localized in the brain. And people threw their hands up. What do we do? He was having seizures every day. He could not really do well in school. He was unable to socialize with his friends. His behavior was more erratic. And we talked about this, and our approach was to do the workup that we described. So we did all of these studies to try to understand what was going on in the brain. Why was he having trouble? Where was the epilepsy starting? What was the network like of the brain function? And after that, we offered this minimally invasive approach called stereo EEG. And we were able to find actually two separate areas of the brain that were involved that were causing different aspects of his seizures. And within 1 week, we offered 2 procedures, one on one side of the brain where we actually removed a large area that was involved. And after he recovered from that, on the other side, it was a much smaller, deeper area. We were able to treat much less invasively with laser. And the idea behind that is under MRI guidance in the operating room, we can actually place a catheter, target a seizure focus, and ablate it under direct visualization in the MRI scanner. And this child went home, and now I get letters and videos and pictures of him horseback riding, skiing with his family. He's back in school. It's just one example that I think illustrates a lot of the points. He was not considered a candidate for surgery. We were able to provide a workup based on all of the latest technology we had in imaging, and we offered sort of the latest in surgical technology for him in a way that was not necessarily conventional, but in a way that we were able to sort of think outside the box and offer them a pathway to a normalcy. And that was incredibly rewarding. And for me, the best part of this is the cards, the emails, the phone calls, the videos. I have boxes and boxes of them, and this is what keeps us going, here in the trenches, if you will.
Absolutely. Well, you talk about the us, and you already mentioned kind of all the your colleagues who are often involved in this care. Could you talk for a moment about that too? How are population health or working across cross-disciplinary teams, how does that all play a role here?
Great question. This is huge. So everything we do is as a team. And I think the epilepsy program really reflects that. As I said, it's, in my mind, the best collaborative team neuroscience. Everybody has a role. We recognize everybody is unique and special on the team and has a voice. And there's no ego. And everyone's aspirational, ambitious for the patient, for the family, for advancing knowledge. And I think that that's played out in so many different ways. From the moment the patient calls, we have a coordinator that will hold their hand and take them through the entire process from beginning to end. We have neurologists, neurosurgeons, my team, nurses, neuropsychologists. They all see the child. We will discuss the case at multiple team conferences. We'll coordinate care in a way that involves everybody. For example, this Tuesday, I'm seeing a child with the neurologist, with the oncologist in clinic together, and we're going to be talking about a surgical approach. But I think the idea here is that the team is really essential. No decisions are made by me individually as the surgeon. Everyone has to meet at a conference and sign off on the surgical plan. There's robust debate. There's back and forth. We call the radiologist. We're very involved in discussing things multiple times. So, and that's really something that has become so apparent in COVID, in the sense that we've had to really double down on this approach and really be nimble and lithe and work together as a team in a way that maybe we haven't before to such an extent. I'll give you one example. We had a child come in from New York with a tumor and seizures, and the tumor was close to the speech center of the brain. So she needed particular mapping. We do mapping of brain function so that we can do the surgery safely and not impact in her seizures. Interestingly, her English was not her first language. And so we had to arrange for testing in her native language, which we did, neuropsychological testing. And once she was in the hospital, she converted to COVID positive. And we had to carry out all of this intense workup with people spending time with this child and the family in person with all of the precautions of COVID. We were able to do the mapping, do the surgery. She went home, her speech is perfect. Seizures stopped. And to me, that's an example of the best example of how we pull together as a team for the benefit of these children. So, I think that's probably one of the most important things. I always teach our residents and fellows, it's not about ego. We're there to do what we can contribute to the welfare of this child. But I think that's sort of in the air here.
Yeah. Well, I want to open the conversation up to our panel in a moment, but just, is there something from the last 2 decades of innovations, or even the last 2 years of COVID, that something else in kind of neurology or neurosurgery that comes to mind that may offer some innovation lessons for the broader field of pediatric care?
Yeah, so really, really cutting edge. And mind you, this all moved forward during the last 2 years of the pandemic. So it's incredible that we've been able to continue, despite the ongoing challenges, to innovate and to embrace innovation. So 2 areas, I can give you 3 areas, but number one, we now have focused ultrasound. I mentioned this earlier, which is a technique where we can treat lesions in the brain, particularly epileptic lesions, tumors, without any incisions at all, based on ultrasound waves in the brain. This is very cutting edge. It's approved for adults with movement disorders, so it's also used for that. But this is sort of the next frontier, sort of keeping up with the theme of expanding access, but minimizing surgery and minimizing the risk of surgery. So this is exactly where the puck is going. And so we have this here, and we're very excited about that, and our patients are very excited about that. The next area that we've started to do with one of my colleagues, Dr. Curry, who's also a huge innovator here, is gene therapy. So human gene therapy treatments. We've now treated several patients for a neurological condition where we replace the genetic defect by introducing this directly into the brain. This is a huge effort involving an entire team, and this is tremendously exciting. And need I say, the floodgates have opened, so to speak. Another area that's incredibly exciting that is more than a couple years old, but I feel we're constantly improving upon this, is fetal surgery. So fetal surgery is a huge area where we can hopefully impact problems before they occur. So one example of that is in a neurological birth defect, a neural tube defect, spina bifida, where children are born with the nervous system literally outside the body. And that's typically treated by surgery immediately after birth. We now, this is well established based on good data, that surgery in the fetus can prevent certain problems such as hydrocephalus, can improve neurologic outcome. What we've added to that process is doing it less invasively with a scope. So we call that fetoscopic neural tube repair. And my colleagues, Dr. Bill Whitehead in neurosurgery and Dr. Michael Belford, who's our OBGYN in chief, have really led the way and now are training other practitioners from around the country. So those are 3 examples of really cutting edge areas where we've embraced innovation, but with the, I'd like to say, the personal touch and the hospitality that we pride ourselves in.
Thank you. That's very helpful. And thank you for all these insights, Dr. Weiner. Don't go anywhere. You're joining our panel in a moment. I want to say that I'm really pleased to broaden the conversation and keep discussing innovation with our other distinguished experts, who I'll introduce in a moment. With us, in addition to Dr. Howard Weiner, are Dr. Rahul Shah, Senior Vice President for the Hospital-Based Specialties Center at Children's National Hospital in Washington, D.C., and Dr. Anthony Chang, Chief Intelligence and Innovation Officer and Medical Director of the Heart Failure Program at Children's Health of Orange County in California. Welcome to you both, and thanks for being with us. Now, I'll turn it over to Kim Castro, Editor and Chief Content Officer at U.S. News and World Report, to continue the conversation. Over to you, Kim.
Thanks, Michael, and thanks to our panelists for joining us today. I'd like to kick things off by discussing the latest news around COVID and young children. The FDA recently delayed authorizing COVID vaccines for children under age 5, much to the dismay of many parents who are anxiously awaiting the chance to vaccinate their young children. So any sense of what's coming down the pike? Dr. Shah, would you like to start?
Yeah, so Kim, thank you for having us and having Children's National at this really important webinar when we think of innovation and innovative care models. We obviously, I have no additional information, Kim, that anybody else would have. Really, we only have our opinions and thoughts. Just really appreciate the thoughtfulness of the CDC and the FDA and how they're going through the regimens, how they're looking at the data. Being here at Children's National, we've really focused our vaccine efforts on vaccine equity, health equity, reaching our underserved patients and populations. So we appreciate the science and the need for the science to be accurate so that we can be trusted messengers for our community. I don't have the secret timeline, Kim, and I don't know when it'll be approved, but I speak for us when we're so appreciative and understanding how we have to get it right for our communities.
Great. And earlier this week, US News hosted a webinar on long COVID, exploring what we know and what we don't yet know. Do you have any sense of the impacts of long COVID in children and young adults? Who would like to weigh in here?
So Kim, do you mind? Yeah, Anthony, why don't you go ahead and then I'll just add a vignette. Anthony, please.
Yeah, since I'm a pediatric cardiologist literally in clinic right now and seeing COVID patients, with many parents asking about long COVID. Fortunately, we're not seeing nearly as high a number of children with myocarditis, either with COVID or with the vaccination that's been portrayed in the media. So, and if they happen to have a little chest pain, it's very mild and very short lasting. So that's the good news. But we don't know what's going to happen a decade or two from now, particularly in the other organ systems, including the brain and the lungs. So that's going to be, I think, quite a challenge for those of us who are in pediatrics. I think a lot of the attention due to the weight of the disease burden in the first year or so has been appropriately on adults, but very little discussion's been on children. And I do think we learned from this whole experience, including the earlier time with adults getting so sick, is that we need a very effective, real-time, real-world data-oriented way to get information. And I think we've learned the hard way that that wasn't available. And I think, as you know, my domain is data science and artificial intelligence. I do think perhaps along with innovation, the other important I word for us this coming decade and next will be intelligence. We need to more effectively deal with real-world situations in real time for not just children, but for adults too. And I think one very obvious example, Kim, is you recall earlier on when so many people were dying, it took us 3 or 4 months to realize that proning patients in the ICU was just as effective, if not better, than ventilating patients. Now, how is it in 2020 that it took us 3 or 4 months to realize that? And people realized that only because the intensivists, including myself, were texting each other that proning was working. And this is, as we all know here, in the pediatric ICU or cardiac ICU that I'm familiar with, proning patients is one of the first things we do when we can't effectively ventilate a patient. And yet that took months. So I think it was a really good reminder for us that we need to work on a real-time, real-world data situation to effectively deal with a pandemic and any other, medical emergency for us.
Mm-hmm. Dr. Shah, you had something to add?
Yeah, just a story, Kim. We're talking about innovation today, and we talked about devices, and Howard mentioned the focused ultrasound, but Howard made a good point. He said, or I'm going to extrapolate Howard, that COVID forced innovations. And I'm thinking of a story of a patient that was referred to Dr. Newman, who, Kim, a pediatric surgeon, our chief executive officer. A patient was referred to him with a constellation of symptoms. I would say this would be February or March of last year. And he was with our chief medical officer, David Wessel, and myself. And we said, could this be what we're thinking in terms of post-COVID or long COVID? And the decision there was to stand up a multidisciplinary clinic. And Kim, if you asked academic medical centers, how long does it take to stand up a clinic? 3 to 6 months, perhaps in the most innovative, if not longer. And then Dr. Newman said, well, our expectation is next week we'll see our first patient, and we need to bring all the specialists together. And you know, Kim, how we are at Children's National, we're the engine that could. So we got it together, and it's amazing. We've seen dozens of patients. I don't like to use the word waiting list because we're screening patients, but there's several more dozen, Kim, that we continue to screen for long COVID. Just as Anthony mentioned, cardiology, Eve Uticum is a cardiothoracic surgeon from Australia. He's actively involved. We have our psychology teams, otolaryngology is necessary, everyone coming together, Kim. And we're seeing as COVID moves from pandemic to endemic, certainly long COVID is here. And we're seeing that with the clinic. I see Anthony, nodding his head. We're seeing that, and the multidisciplinary care model, the innovation that COVID spurred was inspiring, and the patients are there, Kim.
Sure. I want to dig deeper into existing and emerging innovations at each of your institutions. So Dr. Chang, you lead a number of groups, the Artificial Intelligence in Medicine, Pediatrics 2040, International Society of Pediatric Innovation, which has a pretty cool acronym, ISPI, each focused on innovation and future-oriented events or efforts around pediatrics. So can you give us a survey of some of the efforts happening at children's hospitals across the country, as well as some concrete examples of how children's hospitals are using AI today?
Well, I think the exciting thing is that a lot of words are starting with the letter I, and it's not just because I'm from California. But first of all, I want to thank Howard and Raul for their hospitals being members of iSpy, which I think from the beginning almost. So thank you for that. And I think our concept is another important I word, Kim, is international. How children's hospitals should work much closer together, not just in this country, but internationally as well. And we gain so much more insight when we have an international reach to other hospitals. So I think one of the exciting things about all of this, and by the way, my title, as you recall, is Chief Intelligence Innovation Officer, and I got a comment just last week that, well, that was very insightful that you decided to keep both intelligence and innovation together. It was really indecision. I couldn't decide which I wanted to do better, but as it turned out, by luck, the two are going to be very intertwined, and I think in this decade and next, the children's hospitals and leaders by nature have an affinity to work with one another. So that's inter-hospital, interdisciplinary. What we need are the tools to better effectively work together and enable that collaborative spirit. And I think artificial intelligence and with federated learning, which is by far the hottest white topic right now, to share insights from our patients' data without sharing data. I think that's a game changer. And I think it's actually going to change the paradigm of clinical research for the future. I'm extremely excited about that. So if you were to tell me what is the latest and greatest in innovation, and I think devices are always going to be there, but may not be necessarily be the biggest part of innovation. I think innovation is a philosophical cognitive shift to work together any way you can. And I think federated learning and the tools that we have are actually going to enable that. So even though Dr. Weiner, Dr. Shah, and myself are very device-oriented subspecialists, I think by far the biggest innovation is going to be a philosophical shift from working in silos at our institutions to find any way possible to work together and then also take advantage of the other areas that are closely related innovation, such as artificial intelligence, and also clinical research. So at Children's Hospital Orange County, we're actually combining these four areas with leaders in each of those four areas. And I know recently, Raul and Children's National combining innovation with clinical research, and we're adding, at Children's Hospital Orange County, we're actually adding AI on top of that as well, because I think that's ultimately the future, is to really, really take advantage of the esprit de corps of everyone.
Mm-hmm. And Dr. Weiner, I'd like to get your thoughts on what you think, what innovations have emerged, or even because of COVID that are now standard. So, some well-known examples include coordination of care with, other institutions, telemedicine and virtual visits, managing provider burnout and stress. So what are your thoughts here?
Yeah, so we're very active in this area. I also didn't mention anything about COVID at our place, but I have to acknowledge my colleague here, Peter Hotez, obviously, who's done a tremendous amount of work, and there's a lot of, we've done a lot of research together on this. But I would say that obviously telemedicine, telehealth is here to stay. I think that we embraced it early on. It's been a huge benefit for many of our patients who love it. I would also add that it doesn't replace the in-person visit. So, for example, if I see a child on a telemedicine visit whom I think will need surgery, I will insist on seeing them in person with the family. That's just my practice because I think nothing really replaces that in-person human connection, especially if you're going to operate on a child and take care of that child long term. I would say that coordination of the care I mentioned earlier on, some of our patients come from other centers where previously it would be difficult to get people together. Now we can coordinate a teleconference like this, HIPAA compliant, and talk about this child at various centers together. We now have a weekly conference with our colleagues in Israel who are interested in sending interesting epilepsy patients for review. And I think that this was sort of driven by the COVID environment. And I think it's incredible. As far as a focus on burnout, I think that's a huge issue. I gave a talk at our Congress of Neurological Surgeons on this. And my take on this is very straightforward. We focus on our team and we focus on our special work. And I think that the sense of mission, the sense of calling, and the day-to-day things that we do that make our work special. It is such a privilege to be in healthcare, especially in COVID. We focused on that. I think our team has grown and been stronger through COVID, despite the many challenges, the day-to-day challenges. We've become lighter on our feet. We've become more dynamic. It's been a heavy lift to dial care up and down with the numbers, but we've somehow managed. So we've really spent a great deal of time focusing on the team and our patients. We realized as a result of COVID how much we need each other. And, I think that, simultaneous with the progress in innovation is this focus and doubling down on the human aspect of our work, which I think is so important.
Yeah, and so just to continue that thought and the importance of human interaction, Dr. Chang, you've been rethinking hospital and clinic design. So can you tell us about some of the novel approaches you've implemented and what's been the response to those changes?
Well, I think Howard and Raul would enjoy this conversation because I agree with them that perhaps COVID kind of broke the innovation ceiling that we had before, what was possible within what certain time. All of that constraint just, I think, went out the window almost in a few weeks' time. And so that's great news if you have an innovating mindset, because now you're a little bit more liberated than before. And just to give you a couple of examples, Kim, one was about a year before COVID, at our institutional strategic retreat, they asked me for a radical idea about working. And I said, well, here's a really good radical idea, maybe too radical. Get rid of everyone's office. We really don't need offices. We need work areas if we want to get together for meetings, but why should everyone have an office that takes up a tremendous amount of space? Carve out that space for a wellness center or a parent, center. And initially everyone thought that was a little too radical, but a year later, guess what? We're all working from home. And that sort of, now I'm sorry to say it took a pandemic to get that possibility across, but it just makes everyone think that, anything's possible. We just need to really think, very creatively. And the example that you were talking about, Kim, was our Innovation Institute was called into the clinic design team to see if what would be the best place to put the exam table, because people are thinking there are advantages and disadvantages and depending on the angle of the table and everything. And our team came up with a concept that perhaps also partly based on our telemedicine experience that Howard was alluding to, you're invited to the sanctuary of their home during the visit, which was kind of nice. You pick up a lot of signals from looking at someone's house. Why not duplicate that in the clinic and get rid of the exam table and duplicate their living room and just have a sectional couch? You can have perhaps a certain area of the couch be available for a physical examination if you need to, but you really don't need a expensive exam table in the middle of the clinic that takes up a lot of space anyway. So I think our team is seriously entertaining that concept, which I think maybe 3 years ago, pre-COVID, would not have passed even the first discussion. Now people are thinking, why not think very differently about how we do things? And as the author Arundhati Roy, that I think our co-panelists probably know, she wrote about the pandemic as a portal to a new world, and that we should leave our baggages behind. And I think she's absolutely spot on saying that. And this is a great opportunity for us to leap into the next world with just renewed sense of innovation. I think the next 25 years in medicine, and I know it's impressive with the technology, but I think it's going to be the best 25 years in medicine, period, with all the technology, but hopefully with a more important aspect of innovation, which is a change in mindset, that we should seek problems, not just solve problems. And I think that's been missing in innovation as well, is we're always thinking of a solution to a problem, but it really takes everyone to be teammates in trying to clearly identify and define problems for everyone to solve. And there's nothing better than having 25 children's hospitals coming together, as we did this morning, to talk about certain problems and how we can solve. Because even Steve Jobs said, everyone in the room is smarter than the smartest person in the room, and he meant himself, of course. But we need to seek problems together and solve problems together, I think, more than ever. And Howard's absolutely right. This pandemic has one of the biggest dividends is we can just jump on a phone and get 5 to 10 institutions to come together and really make a big difference in terms of getting problems solved very quickly. There's no longer, well, let's meet in 3 months in person. To just get on the phone within a week, we can organize something. And exciting part of iSpy is we're convening about close to 20 children's hospitals to focus on AI as a resource as well. That would not have happened this quickly pre-COVID. It would have taken a year to organize this group, and it took 3 weeks basically to reach almost 20 children's hospitals. So I think I'm very encouraged by this velocity change in how we innovate and how we get things done together.
Mm-hmm. Go ahead, Dr. Shah.
Yeah, so just reflecting on some of the comments, Anthony, I love that word, innovation ceiling. I don't know if that's been coined elsewhere, but heretofore, I'll give you credit for it. I really like that.
Made it
the
up.
Pandemic accelerator. Yeah, well, I'll give it to you, Dr. Chang, innovation ceiling. So Kim, it was interesting when we put Howard and Anthony's comments together during the pandemic, we opened up a telemedicine command center. And when we think of telemedicine, we all generalize that to outward looking or communicating externally. But Dr. Chang knows this. I think he's visited it with us a little bit. In the middle of our cardiac intensive care unit, Kim, so there are 26 beds. In the middle of it, you open a door and it's an oasis. There's soft blue lighting. But not only is it an oasis, there's about a dozen workstations. You have one for the charge nurse, one for somebody who's manning the command center, one for a sonographer, and they're all coming together to take care of our 26 patients in the unit, Kim. So it's not external, it's actually internal. And we talk about that innovation ceiling with the Great Resignation. How do we handle a workforce shortage? Or how do we handle acutely critically ill children? Well, using this telemedicine command center, we have a belt and suspender approach. If you have a physician and nurse working on a sick child over here, we know that another team is looking at that baby over there on the monitor. And it's certainly not AI or machine learning, but it's simplistic predictive algorithms. This is what your pulse ox looks like. This is the heart rate. This is the EKG. You then flip that screen red, and the team knows to go over there. But as Tony said, it's happening right now, and it's more of a way to drive internal outcomes and also how we help with our own challenges in healthcare with staffing. So that's an internal innovation model, Kim.
Right. And actually, I'd like to get your thoughts on the Research and Innovation Campus at Children's National at Walter Reed Army Medical Center. So can you tell us a little bit more about that campus and what it allows the Children's National community to do differently?
Yeah, for sure. Really excited about it. When we talk about innovation, perhaps many of us would have entered today's webinar with that thought. Children's National Research Innovation Campus is a hub. First of all, it brings partners. So Johnson & Johnson's innovation group, J-Labs. It's one of the 10 sites in the country where J-Labs is based out of. Virginia Tech. So we have a strong academic partner, all coming together to tackle those significant problems for pediatrics. It reminds me of a great quote attributed to one of our nurses here at Children's. Kim, I don't know if you've heard us say this, but only in pediatrics can you save a lifetime. So I love that. Only in pediatrics can you save a lifetime. So Yves de Udekum, our chief of cardiac surgery, is asking, why do we have ventricular assist devices for adults? Where are they for our neonates and our youngest children? So that's what the Research and Innovation Campus allows us to do, tackle those big problems geared towards children. It's fortuitous that it's built on the Walter Reed Medical Center campus, Kim, as you said, which is a couple miles south of the National Institute of Health, the Food and Drug Administration, a couple miles north of Congress. It's right in the center of where innovation has to happen. But interestingly, we also take care of patients there. And so we have our complex care program that is also based there right next to our Rare Disease Institute. So by putting these programs together, we're able to leverage the synergies of a huge genetics program taking care of complex children that might be able to put translational innovation into place, research or innovation or care models.
Great, thank you. So moving on to another important topic that we cover extensively at US News, which is health equity. So how can you balance innovation and equity? So for example, reaching kids in need of complex care, but also making sure that those who might not have the easiest access to your hospitals don't get left behind. How are your institutions working to ensure that they're innovating for all kids and families? So Dr. Weiner, would you like to weigh in on that?
Yeah, this is a huge issue, and I'm very proud of our organization. We work very closely with the state of Texas to provide care to many, many children in this exact category in need. So these are children that are coming to our multidisciplinary clinics every single day. We have a tremendous electronic medical record campaign for access. So all of our patients now can book appointments directly from their telephone. They can review all of their results and findings, and they can interact with the medical team directly, and all of our children have access to this. I think that we are a referral center for pretty much most of Texas, certainly the southern part of Texas, and we have pediatric clinics throughout the Houston and greater Houston area. So we're seeing children of all different demographics come to us and have complete open access to us. And this is an area where I think we've done a much better job than I've seen in other institutions that have been at.
Mm-hmm.
And can I just add to that? I think we have, a neurosurgeon in Howard, a ENT surgeon in Rahu, and a pediatric cardiologist and myself. I think what's going to be really key this decade is driving innovation to not just equity, but for primary care as well. We all three of us rely on good primary care and our pediatricians to take care of the patients before and after our procedures. And there's so many stories about how the most technologically advanced procedure was done and the child died of diarrhea and dehydration. So I think we really need to also drive innovation towards primary care. And since I think I'm the only pediatrician in this group, although Howard and Raul work with children, I think we just want to put that thing in for thinking about equity and also access, but also driving that in primary care. And I think one of the exciting projects that we're involved in here in Southern California is driving AI for health. You may or may not know that this generation, coming generation, is going to live shorter than the previous generation for the first time since the Second World War. That's a public health emergency. And in some ethnic groups, 5 years shorter. than previously. So I think we're really, really, and not just the pandemic being a public health emergency, but we have the follow-up emergency, which is people are going to live shorter unless we do something with access, equity, and primary care. And I think that's really going to take all of us putting our minds together to how do we leverage data, information, and AI now to assure equity in access and information as well.
Mhm.
And what I would add is, what's incredible is all of the technological advances that I had mentioned, the focused ultrasound, the gene therapy, the laser ablation, the stereo EEG, all of these things are offered with equal access to all of our patients. There's no limit, there's no barrier. And if you look at the 1,200 patients that have surgery every year, there's every single background and demographic. It's really inspiring, actually.
Mhm.
Kim,
yes, go ahead.
no, we're not making this easy for you, Kim. Sorry.
That's great.
One thing we also think about is we have to go to where the kids are. And so at Children's National, we focus a lot of our efforts on wards 7 and 8. Here in the district, we have wards, which are synonymous to counties or jurisdictions, and we go to where they're underserved. We partner with the medical centers to stand up an emergency department. We're partnering with George Washington University. Kim, you know the new hospital, the Cedar Hill Regional Medical Center will be opening in partnership with GW, putting a NICU in there, putting an emergency department. So Kim, that's one strategy when we think about health equity, patients coming to us, but also the onus is on us as academic medical centers to get out in the communities.
Mm-hmm. Mm-hmm.
The innovation, Kim, is, and I'm looking at Howard and Raul because they're, I think, agreeing with this philosophy of not just having the Children's Hospital be the tertiary partner center, but actually actively involved in children's health in your region. And that's a huge philosophical shift from the time that we were in training. We were just reminiscing this morning about my early days at Children's National about 35 years ago. It was all about Children's Hospital. And now I think some of us even changed our hospital's name, including ours, to Children's Health of Orange County rather than Children's Hospital of Orange County. And I think that's more than just a sort of a marketing thing. It's really, we want everyone to think differently about the Children's Hospital, not just as a sanctuary for tertiary and quaternary care, but as a delivery system for children's health in the county and in the region, and be very, very influential with school systems and parents at home, and be the ultimate health resource.
Yeah, we have a full network of Texas children's pediatricians throughout the greater Houston area, which I think is tremendous, and many, many subspecialty clinics out in the community as well. So, this is all in keeping with everything that we've heard, going out into the community to serve our children and their families.
I think gives the pediatrics, I was just saying, gives the pediatric subspecialist an added reward when you know that you're also accountable for the children's health and not just do a procedure. And I think we haven't had that mindset before either. And I think, we're losing a quarter to a third of clinicians potentially in the next few years, incredibly. And yet there are more young people applying to medical schools than ever before. It's a historical high. So all of us need to leave an amazing platform and ecosystem for the younger generation. Because despite the pandemic, and for the first time, doctors can lose their lives being clinicians, more young people want to be a doctor than ever before, or a nurse than ever before. So we really, really are accountable to this next younger generation. And that's the other thing about innovation, Kim, that I think is very exciting, is how do we teach the next generation to be innovative? And how can they teach us to be innovative? Because I think it's a circular mentorship for innovation, is we need to listen to our younger generation also.
Mm-hmm. Well, I want to briefly switch gears, and I'd like to get your thoughts on delayed care. So delayed care and missed appointments, screenings has always been a concern, but obviously exacerbated by COVID. So Dr. Schott, how deep a concern is this, especially for, say, pediatric cancer care?
Yeah. So Kim, probably early on in the pandemic, and I'm going to reflect back here, March 15th was our first patient at Children's National. I think there's so many lessons learned. And Howard and Anthony, I hope I speak for all of us when I say most children's care is not elective. And I'll just stop right there, Kim. And that's okay when we had a mortality rate of almost 10% in New York, when, as Anthony said, we were learning new care models. We understand that things had to be paused. But let's even talk about vaccines, Kim. When we have children that aren't getting to the primary care appointments because they're missed or delayed. So it's not only specialty care and subspecialty, but it's overall delayed care. The exciting thing, and Anthony, I'll go back to this innovation ceiling, which I hope we've broken through in COVID, is innovative care models have allowed us to expand our reaches. Telemedicine, nights and weekends, also opening up clinics, expanding capacity, opening up school-based clinics. So at Children's National, especially with our primary service area, we've been very aggressive to make sure we serve the kids. When they get their COVID vaccines, let's make sure they've gotten their other vaccines and their other schedules. So it's really been top of mind for us, Kim, and I think for a lot of pediatrics, once we went over the alpha and beta wave of the COVID variant, perhaps a little bit differently than in the adult world.
I would absolutely agree that elective is a misnomer. We've certainly learned that. Early on, we were able to triage patients. What was absolutely emergent was about half of our practice. But the types of disorders that I was mentioning, like epilepsy, the clock is ticking. And so this is not an elective procedure. I'll give you one example. Yesterday in clinic, I saw a baby with a mom who I took care of, who presented early on in COVID and needed to come in for a ketogenic diet by a neurologist and was basically delayed somewhat. And surgery was delayed because it was considered elective. We got that child in, we did the surgery. The child had severe epilepsy and is now seizure-free and is doing very well. But we were all very nervous at that time. So I think that we've managed to, as I've mentioned earlier, pull the team together and run through hoops and do incredible amount of dynamic scheduling, planning, working around the clock. I can't emphasize enough the importance of the team approach to get these patients in and through and cared for. So yes, we learned very quickly that elective is not a term that applies to pediatric care.
Kim, I don't know how you can look at a family, and Kim and I know families in common, how you can look at a family and say that, oh, your child doesn't need to be healthy. And that's essentially what we're saying when we talk about delayed care elective. I'm flipping the paradigm and I'm being provocative, but we want to give healthy children to the parents. And I think that's where Howard, Anthony, and I are very adamant about ensuring that delayed care doesn't happen. Even with the Omicron surge, even at Children's National, we knew we had 5x the amount of patients that we had throughout the pandemic because of the Omicron surge. Parents were understanding. Patients understood. We would set up separate COVID testing. But going back to the video EEGs that Howard's talking about, we wouldn't cancel those because we can't delay care. We just have to think of innovative care models.
I do agree with Howard and with his comment earlier on that, you know, even though we kind of enabled telehealth very quickly due to the emergency, I would say 90% of my families much rather see me in person. And that's something probably different about pediatric families, that they're not going to be as content as adult patients with chronic care, that they can have a televisit and be happy with that. Most of our families, even for something that's relatively I'll never say insignificant, but minor, they still want that reassurance from the pediatric subspecialist in person. And the televisit just doesn't do it for them. And I think that's a good thing. That's inspirational for us, that our families think that way of us, that they would not necessarily go with a televisit. They want to see us in person. So that's a tremendous privilege for all of us taking care of children.
And what I would add to that is what was incredible to see is families traveling at great inconvenience, great cost, from out of state, from remote areas in the midst of COVID to advocate for their child. And we worked together with them to make this happen with all of the risks of COVID, all the inconveniences of COVID. And we were able to coordinate this care in ways that seemed almost impossible. So I think all three of us are sort of sharing a similar theme about, sort of how COVID sort of revealed sort of the importance of what we do day to day.
And also we have to unlearn, Howard, unlearn to innovate. And sometimes the mindset is so fixed, and that clinic exam table is an example. We're just so used to having that around. And innovating is not putting it at a different angle. Innovating is maybe rethink whether or not we need something in the first place. And I think that's the nice thing about the telehealth is that it's not, it was technology that was available for 4 or 5 decades already. We just never enabled it. But what will be innovative is not making sure we have telehealth, but how to use that in an innovative way, perhaps to have multinational patient conferences much more easier than before, is to how to, or merge it with another technology, Kim, like, sensor technology and all of that. So I think what's going to make telehealth innovative is to add something that wasn't there before.
Thank you. And I want to be mindful of the time. I know we only have a few minutes left, so I'm going to take some audience questions. I do see one question here for Dr. Chang. You mentioned international outreach and the integration with innovation as global health practitioners and leaders. How do you envision this type of collaboration? How does your center support this endeavor?
Well, I'm grateful to Kim Kripe, our CEO, and our hospital for giving me the opportunity and time to try to convene as many children's hospitals as possible, not just here in the US, but internationally. And we're happy to say that we have several international hospitals, including one in Africa. So my vision is to disseminate information across the globe so that I lost it, and it's a personal mission for me because I lost a patient, a 9-year-old in Myanmar, on a consult because that I saw initially, there was not enough information going to that center to help that child, and that child eventually died. And the solution would have been relatively simple. So and that was about 8-9 years ago. So I vowed that I would try to get information from the best hospitals like the ones here to, that expertise should be available to a children's hospital in Africa. And because with information technology and now artificial intelligence, we should be able to activate that across the globe so that we don't necessarily need to always have parents take their children to a specific children's hospital. That most of the time, short of surgical expertise, that's hard to replace. But I think medical knowledge for children should be democratized across the globe. And I'm very excited to announce a project that we're doing actually using federated learning so that 7 or 8 children's hospitals can share in pediatric imaging without sharing the data, but sharing the insights so that it can be automated. So wouldn't it be nice if a pediatric practitioner in Africa can get a interpretation of a brain MRI without having to really look for that person or read that study? So, and I think technology is available. We just have to have the vision and the tenacity to execute that vision. It will be very sad if we don't use and leverage the technology that's available today to benefit children's health, not just in this country, but around the world.
Well said. So any final thoughts, Dr. Shah, Dr. Weiner?
I would just thank you for bringing us together and thinking about innovation broadly. We didn't hear a lot of talk about devices and medical clearance. We heard about care models, putting patients first. And that's really exciting, Kim, because it's changing how we think about innovation. So it was a pleasure to be here with 2 great colleagues. Thank you, Kim.
Yes, I reiterate that. It's been an absolute pleasure. I think pediatric healthcare is very exciting right now. We're really optimistic. And I think despite the challenges of COVID, we've come out stronger. And we recognize all the people that have suffered through this. We have personal stories of this, but I think that we're going to come out stronger despite that. So thank you for the opportunity.
Of course, thank you.
Thank you, Kim, for highlighting pediatric innovation, which is not a topic that you commonly hear. And I give kudos to the U.S. News and World Report, and perhaps think about innovation even more in your world famous metrics, and really put substance behind that, as well as artificial intelligence. I think innovation and intelligence will get us through the next few decades and really change how and transform our practice.
Point well taken. So thank you so much to our STEAM panel of speakers for sharing their experience and great wisdom with us today. As always, I encourage our audience to go to health.usnews.com for more advice, information, tools, and of course, our best children's hospitals ranking. So on behalf of US News, thank you for your time. We hope you found this helpful. Enjoy the rest of your week.